Hello and welcome to today's Journal Live event with the Kansas Leadership Center. Today's topic is Sustaining Rural Healthcare. Here's your host, Managing Editor of the Journal, Chris Green.
In the census figures that were released earlier this month, 80 of 105 Kansas counties lost population. And that loss is connected to another loss that rural communities are grappling with right now. Many residents, an increasing number, fear losing their local hospitals. A deepening crisis in Kansas healthcare means that more and more places are having to confront this possibility. At least 6 Kansas hospitals have closed over the past decade, including one in Fort Scott. And I learned a lot about that particular closure from the reporting of Jane Tribble of Kaiser Health News, who returned home to Kansas to do extensive reporting on the situation there for No Mercy, season 1 of a podcast called Where It Hurts. And it's not just Fort Scott. 75 of the state's 99 rural hospitals have been operating in the red. There are a range of factors at play: shifting demographics, growing rates of uninsurance, workforce shortages, healthcare financing changes, and public health challenges that are forcing communities to think about, well, how do we adapt to this new reality? In the summer edition of the Journal, the Kansas Leadership Center's magazine, PJ Griekspoor reports on a proposal pending in Decatur County that offers some hope as a model for survival. The approach under discussion there could help hospitals hold on to crucial services such as 24/7 emergency care. But that transition comes with some pretty significant trade-offs. I'm here today with Jane Tribble, senior correspondent at Kaiser Health News, Jennifer Finley, Vice President of Education and Special Projects at the Kansas Hospital Association, Kris Mathews, the Chief Operating Officer of Decatur Health, and PJ Griekspoor, the Journal contributor who wrote the story, to discuss the challenges related to rural hospitals and sustaining healthcare in rural communities. And this is a conversation that we don't want you to just watch. We want you to be a part of it. So please post comments, questions in the chat, and we will be periodically checking in and trying to give our panelists a chance to answer some of your questions or respond to what you bring up. But I want to kick off today's discussion by turning to PJ and having you tell us a little bit about your story. What got you into this topic? What made you interested? And what did you learn through your reporting about sustaining rural healthcare?
Well, I've been interested in following developments in Kansas rural healthcare for several years as editor of Kansas Farmer Magazine in my pre-retirement career. So it's an issue that's been on my mind. I have 2 son-in-laws who are paramedics and a granddaughter who's an EMT studying to be a paramedic. They work in Cowley and Sumner County. So I've kind of followed along with some of the struggles that have been happening to rural hospitals over the last decade or more, where the struggles have become harder and harder to endure. And as we've seen with the Fort Scott and Independence and others, impossible to sustain. So when this model arrived, that the Kansas Hospital Association was looking at holding community meetings and seeing if they could make people aware and perhaps come up with an idea for introducing a delivery of care system that would be sustainable for these rural communities and that would maybe look into the future at what kind of challenges they were going to continue to face and figure out what can we do to make sure that when the semi crosses the center line, there's somebody to respond to the victim. And I know that a lot of people don't think much about, well, why don't they just go to the nearest regional hub or whatever? But I think COVID showed us that when you have a situation where there's emergencies, you need immediate local response. There isn't really time to get a decent delivery of care if you don't have somebody to respond in the short time, and at least have the ability to stabilize someone so that they are capable of being transported to a larger regional hub for more intensive care. So when I got the word that these community meetings were taking place, I signed up to attend the seminars, and then COVID hit and everything had to go virtual. But having known what was going on with the Centers for Medicaid, Medicare Services, and that they had approved this new model that would allow a community to take emergency hospital status, not have inpatient rooms, but would be able to keep 24/7 emergency care, and perhaps even offer some services that they can't offer now that might be revenue producing, like substance abuse or mental health services, or other things that are ongoing care for chronic conditions, or things that might bring in some more revenue from the existing population. So with that in mind, and CMS saying it's good to go January 1st of 2023, it just seemed like a good time to get the word out that this was a possibility that might happen in rural communities, and that the residents would really want to get involved and have a say about what that system looked like in their community. And I think there's enough wiggle room in this plan from CMS that communities would have a say. This would not have to look exactly alike in all the counties of Kansas. There could be a model that would work well in extreme rural Kansas, like Decatur County, but that might be modified if you were talking Brown County, where you're, or Sedgwick County, where you are much closer to a major regional hub hospital.
So yeah, that's interesting. And so help me out here and make sure that I have this right. So like under like this model, like there'd still be a hospital there, and there'd still be emergency care, but what's in that hospital might be a little different than what's before. And like people aren't staying there 2, 3, 4 days, which they aren't anyway anymore. Like, is that what do you think the biggest changes are? And how did residents react when they started discussing them?
Well, I think the biggest thing that people were concerned about, and I think this is true of the hospitals, and Kris, you can correct me if I'm wrong, but the hospitals have a concern about keeping their swing beds, about being able to still bring, say, someone has to have open heart surgery, and they're going to need 2 weeks of care, but not necessarily 2 weeks of intensive care. Can those patients come back in a convalescent room in their local hospital? And local hospital authorities are very concerned about that, because that is kind of bread and butter revenue for local hospitals, is that convalescent care for people. And I don't know if those could be structured more as where it would be more like nursing home reimbursement. I'm not sure how that would work, and I'm not sure what's in the plan. Jennifer might be able to better address that.
So I kind of want to pull back here for a second and turn to Sarah Jane Tribble of Kaiser Health News. So one of the things we really believe in deeply at the Journal is in-depth reporting and stuff that really gets the context and the details right. And I learned so much from Sarah's series on Fort Scott. And what I loved about it was, well, one, it was by no means like a fly in, fly out. It was like lots of time. Like they might have given you residency by the time you were done with the thing. I also loved like what you learned and what you were able to unravel over the course about like why it matters that a community loses its hospital, and how, just going back to this rural emergency model, like why it matters that communities might want to start planning for it, which is something that Fort Scott didn't really have the opportunity to do. So, and the other thing that I really loved about it was it got into like some of the real consequences for people who live there, from everything to travel time to preventative care, as well as like just the emotional blow that losing your hospital and losing that particular hospital had for that rural community. So I kind of want to take you back, Sarah, and maybe tell me like what drew you to cover that story, and what was most interesting to you about Mercy Hospital and Fort Scott?
Well, first of all, thank you for having me. And let me warn you, I can talk forever about this. I worked on this story for 2 years approximately. First, it was a series with NPR where we had 4-minute stories and interviews with NPR with every published report called No Mercy. And then I came back, and during the year of reporting I did with NPR, I had been collecting hours and hours of tape, and we came back and produced a narrative podcast. Each episode or chapter of the podcast is centered on a person who highlights a healthcare issue, if you will, or a topic. So there's the idea of primary care, and there's an episode with Rita Baker, the former CEO of Mercy Hospital, and she's guiding me through closing up the hospital. And that episode talks a lot about the economics around why Mercy Hospital closed and why a lot of rural hospitals closed, and some of the efforts that were done. What drew me to the story was the fact that I'm from southeastern Kansas. I grew up there. I grew up on a dirt road, about an hour from Fort Scott itself. I remember going there on field trips and enjoying the community and thinking it was a wonderful, vibrant community. I had been going back home a lot when this story came upon KHN, because my sister lived in Kansas City and she'd been sick with pancreatic cancer. And so I had was talking to my family all the time, knowing that Independence nearby had closed a hospital, that Mercy, the health system itself, had closed the Independence Hospital. When my mom called me in October of, I guess it was 2018 now, and told me that Mercy was closing the hospital in Fort Scott, I knew it would be a big blow, both to southeastern Kansas and also just to that community. And what struck me, I've been a healthcare reporter since graduating from college in the 1990s. I was a healthcare reporter at the Wichita Eagle, a business reporter, and I covered some healthcare stories. So I've covered other hospital closings in rural settings, but mostly in urban settings. And so I went to my editors and I said, if you want to have an example of Medicaid expansion being needed, this might be a story. I didn't know the background about the economics behind Mercy Hospital closing at the time. I just knew that Kansas hadn't passed Medicaid expansion. That certainly would have played a factor in the revenues in some way. Maybe didn't keep it open or close it, but would have played a factor. So those were kind of the thought processes going into my head when I started working on the story.
And when you started getting in deeper, what were the things that were most interesting to you or surprised you the most as you went through the process of reporting this?
I was surprised right off the bat on my first trip about the animosity and anger about the hospital closing. I expected disappointment and sadness and grief. I did not expect the anger that I found in the community. And you made a comment about residency. Every time I went back, I would stay for at least 3 to 4 days. And I always would make a point of staying at the 2 local hotels, a bed and breakfast and another one, because I wanted to be as much in the community as possible. And I would then always go visit my parents too. So I was usually there for a week at a time in southeastern Kansas when I went back. But when I went back that first time, there was obvious animosity in the air. And Rita, the former CEO, she's still in Fort Scott or in the region working on healthcare and trying to improve lives there. She had invited me to tag along with her to a community coffee. And I knew that she had been very active in the Rotary Club and the Elks, and just very active in the community. Rita Baker is the sort of healthcare leader that, was participating in the Kansas Hospital Association. Jennifer could probably talk more about that. But I know at one point while I was covering her, she didn't tell me she was in DC lobbying Congress. And I was like, wait, why didn't I know about that? So I know she's very active in the community too. She'd been the CEO of the hospital for more than half. She'd been at the hospital more than half her life. She'd been the CEO for a number of years, very ingrained in the community. She took me to the community coffee. She walks in, nobody talks to her. Nobody. And I'm watching her and she has a smile on her face, but the normal interaction that would happen wasn't happening. And then when I was at the bed and breakfast one night, I got a call and I was connected with the city manager at the time. And he really, really wanted to make his case. He really wanted Fort Scott to make their case about this hospital. And between those two events, I knew that there was a lot of friction in the community about the hospital closing.
And through your reporting, did you get a sense of what was behind that? What was driving that? Why was it so different from what you might expect, or for these interactions to be so different from what would be typical in a rural community?
Well, so Mercy Hospital in Fort Scott had been there for 130 plus years. It was opened by nuns, the Sisters of Mercy. It was the first Kansas hospital opened by that particular branch of the Sisters of Mercy, and it had always taken care of Fort Scott. I think that there had been concerns through a process called discernment, where Mercy had considered closing the hospital previously. I just don't think anybody believed that the hospital could close. It had built a new big facility in 2002, and they just didn't take seriously the actual chance that it could close. They thought it was a big, beautiful hospital on a hill. There were plenty of staff members, people working there. It was one of the biggest employers in town. People who worked there had very, good pay, and they had good benefits, but they didn't. They just didn't believe it, and I think that's where the anger came in.
And does the situation that was in Fort Scott with the hospital, does that feel like like a unique story just to Fort Scott, or do you see that as being sort of a case in point for what any rural community could experience in terms of their hospital?
Yeah, I think one of the reasons Kaiser Health News wanted to invest so much time and energy in it is because it is kind of a case in point to what's happening across the US. If you look at a map of rural hospital closures, Kansas certainly has its fair share, Tennessee, Texas, a lot of the South. Many of these hospitals have been around a long time. Many of the buildings were paid for through government funding in the 1950s and 60s. So these are communities that grew up knowing that their babies were born in their communities. They knew their nurses, they knew their doctors. This is a fading of a lifestyle, really, in these communities. And when you look at the touch points for how we reported out Mercy Hospital, what we try to do is focus on some of those critical needs that those communities still need, and figure out what lessons we could take from the loss of those facilities, or perhaps maybe the saving of those services as well.
Well, and I'm glad you mentioned babies, because that's one of the topics that comes up in the podcast. Could you tell us a little bit about, well, how did things change for patients once that hospital closed, and how did they get care, and how did that evolve over time?
The year before Mercy Hospital closed, there were more than 230 babies that were born at the hospital. So this was one of their biggest service lines that continued as the hospital downgraded and lost staff over the years. And so this was a big hit. I mean, out on the highway, the hospital was positioned on one side of town, and they had a big sign where a baby's face would go up once it was born with the family's name on it. So the loss of the hospital for this particular community, they were, one could say, lucky. They had a hospital nearby that took over the emergency department, and you could easily get transferred to Via Christi in Pittsburgh. The challenge with that, though, is if you're used to a 10-minute drive to the hospital, or if you're on the south side or another side of town, that drive isn't 40 minutes or 30 minutes, it's 45, 50 minutes. And when you introduce that kind of drive into maternity care for an expectant mother, babies don't always follow a timeline. Like you can't always determine when a baby comes. You can do a C-section, you can do all sorts of planning around it, but babies don't always follow a timeline. And I think that really scared a lot of people in the community. And then just kind of the emotional toll of not having your children born in your community. It kind of makes you question what the definition of a community is.
And then there were also maybe some heartbreaking stories in there about access to emergency services and what that means to patients. Any examples that come to mind?
Well, yeah, I mean, I was at a city hall meeting in Fort Scott after the hospital closed. It was a very cold, icy February, and I went to the local pub afterwards to grab myself dinner and a beer. And I was eating, I was kind of off work, and a woman comes up to me at the bar and says, "I saw you at that city hall meeting. You're the reporter in town." And I said, "Yeah, that's me." And she said I had to hear the story of Robert Finley. And Robert was a very popular auto body mechanic. He made cars look really good. He was from Fort Scott, grew up there, went to high school there, and he had died during what they call the dark period. So when Fort Scott Hospital closed, they kept the emergency department open for another 30 days. And so the emergency department didn't close until the end of January 2019. then there was a dark period between when Via Christi in Pittsburgh was able to reopen that emergency department for certification reasons and so forth. And so there was a couple of weeks there where there was absolutely no emergency room there. And that's when Robert Finley fell and hit his head.
And what ended up happening with Robert?
Well, Robert hit his head in the evening and he slept on it. And he woke up very early in the morning and they called 911. And there was no emergency room for him to go to. So the dispatcher automatically tried to find air helicopter service. And this was probably the most surprising thing to me from being just from rural America and not knowing this already. I feel like I know a lot about healthcare, covering it off and on for the last 20 plus years. But the air helicopter services are private. So they operate in their own networks and they work together. But, there's always staffing. You've got to be concerned about staffing. You've got to be concerned about, how far those helicopters have to travel. And what I really didn't know was how much the weather can impact it. And so they were turned down by several helicopters before one could come. And that prolonged the amount of time Robert was in the back of an ambulance. And because the emergency department was closed, they were hand intubating him, hand pumping air into him in the back of an ambulance for at least 30 minutes. I had requested a 911 tape and listened to it. And Linda, his wife, had driven out there. And in her panic, she'd forgotten that the hospital was closed. And she shows up and there's a cardboard sign on the door. And there's somebody inside working to refurbish it. So they answer it and they're like, well, he's in the ambulance out behind you. And she has to skid across the ice to get to the ambulance. Robert died from his injuries. Who's to say if he would have passed anyway? I think what's critical there is there was nothing there to help him at that moment. And Kris can help me out here, but there's a saying in emergency care, and minutes are muscle, right? Every minute that passes is more danger for the patient. And so without an emergency room or department, it's more likely those minutes are going to pass.
Yeah, and that was one of the stories that drove home for me why this planning, these conversations about what healthcare should be in rural communities, like having them be proactive. There could be a lot of value, not just in community sustainability, but in even saving lives as a result of that those services are always there. I don't want to give away the ending or anything, but it seems like one of the things that happens over time is that Fort Scott, adapts and evolves and, finds a way to cope with both the patient and care type aspects of it, as well as the emotional aspects of losing a hospital. So could you tell me, what do we know about what's working with that transition, and what are the things that they're still working to overcome?
Well, when Fort Scott closed their hospital, Rita Baker had contacted a large community health center, and FQHC is what they're called. They're federally qualified health centers. They get special funding. They can do discount drugs and so forth. So when the hospital closed, that FQHC Health Center group took over the 4 primary care health centers that Mercy had operated in town and in the region. And that was a tremendous thing that happened for the community, because that meant they kept their basic services, right? You could keep going to your doctor. This healthcare center hired all the local doctors they could, and you could keep up with your medications. Maybe when I went back afterwards, people were thrilled that the medications were cheaper than they could get them at Mercy Hospital. So there were some bonuses there. The other thing that health clinics can do that hospitals can't do as easily because of the funding mechanisms behind it. Hospitals aren't paid the same for some outpatient services like addiction services and mental health behavioral services. And so the FQHC could bring that to town. They were working on bringing dental last time I talked to them as well. There was also an emergency department that came, like I mentioned, that came because 30 miles away was Via Christi. So they opened up an emergency department in the community, and that helped feed inpatient beds into their Pittsburgh hospital so they could pay for that. The other thing that occurred in that emergency department that I want to mention after we talked about babies is there was a warmer what they call a warmer. So if somebody did have an emergency with a delivery, they could take care of that baby until they could get it into an inpatient room with its mother. So those were very promising things. I will say that since my reporting officially finished, I've heard that the community there's still members of the community that really, really want a hospital. It's really hard to give up the idea of a hospital when you have a big, beautiful building sitting on a hill. And also when you've had a hospital for a long time. And so I will say that there are people in the community that still want that hospital to come back. And I think there are efforts towards that. However, when you look at the Medicare payment mechanisms that are in place for hospitals and the new model that we're talking about today, I do think that, when you consider primary care services and emergency services, those are two top things that a community needs. And then there are other services that I'm sure we'll talk about today that a community needs, such as maternity care. And then on the flip side, there are services that the community lost that they will probably never get back, right? Like the cancer care center that was there where people could go and get their chemotherapy and doctors would travel in every week or so to see their patients. That was not expected to shut down immediately, but it did because there were just so many changes in the community. And so that may not return to the community at all. And I think some communities will have to come to terms with the fact that specialty care is just that. They're going to have to drive out of town for it.
So even with the adaptation, like still significant changes and still significant feelings to be sorted through in that community. And so thank you, Sarah, for that summary and for your work on that podcast and for coming to Kansas and telling that story on a national stage. I just found it so insightful to listen to. I'd like to switch to talking to Jennifer and Kris about the rural emergency model. But before I do so, I want to check in with Sam Smith, who's monitoring Facebook chat and comments. Anything going on in terms of discussion or questions that we might need to tackle, Sam?
Yeah, Kris, can you hear me okay?
Yes.
Yeah, so we had a number of comments. Shirley Hansel of Wellington talks about the need to adapt for the sake of the community. CJ Robinson, who may be from Oberlin, said that lots of people have been affected because of the closing and lots of jobs have been lost. Jack Gregory mentioned that Mercy had a hospital in Fredonia and withdrew their sponsorship in the 1980s, but the community rallied to keep the hospital under leadership of the city. And then Dave Herdman asks a question. I see pushback on the idea of Medicaid, whether understood or not. Can any of these things be accomplished without Medicaid approval? And he lists things like holistic medicine, where we focus on prevention, nutrition, well-being, checkups. Can this augment the billing and improve the health? And he mentions the example of Costa Rica, a largely rural country that tackled this issue over the past 10 years. And now their life expectancy surpasses that of the United States. So he's wondering whether any of these kinds of things can be accomplished without Medicaid approval. So that would be the one pending question.
Okay. Well, and this is a question that I think versions of it came up in our chat leading up to this event about the role that Medicaid expansion might play. It's been long debated in Kansas, has become close to becoming law on several occasions, has never made it, and tends to have a less of a likely fate with the current political composition of the legislature. So maybe Jennifer and Kris, this is a good chance for you to jump in before we get into the rural emergency model and maybe tackle the elephant in the room of Medicaid expansion and like where that factors in for rural hospitals and what that could address and what it couldn't address.
May I just say one thing first, because this is a question that's come up often. I've been a healthcare reporter a long time, and I have not talked to a hospital leader who didn't want Medicaid expansion. And that's because it pays for patients who perhaps can't pay, right? And so if you have patients who can't pay and suddenly you have a payment mechanism, that means you can pay for services like those primary care services. So just sort of as a foundation, I think that you're going to hear from hospitals, but as a reporter who's covered a lot of different things in healthcare, I've never run into a hospital director, administrator who didn't want Medicaid expansion simply for the fact that it gives them extra revenues.
Mm-hmm.
Well, can I kind of change it? You can run into one hospital administrator that's a little, because typically what happens is that you have a lot of folks that can't afford insurance. And so when you expand Medicaid, then magically they're able to get onto Medicaid and then come and see. But what a lot of people don't talk about is some of those folks that are purchasing the commercial insurance right now, that, hey, I now, my income is low enough that I can get on Medicaid. And so there's a lot of folks that are on the commercial insurance that when you expand it, they come onto the Medicaid as well. And so it's about have to have. So really as a hospital, I'm only planning if Medicaid expansion does happen in Kansas, I'm not planning for additional revenues. I think it's going to be about a flat, it's going to come out. But I mean, if it does, then I guess we'll be a lot better off with some additional revenues that we would not be planning for. But anything that would engage the community to take an active participation in their health, if it's insurance, access to insurance, that's one of the reasons why they're not coming in to get an annual checkup, why they're not coming in to see the doctor, then anything that helps that I'd be in support of.
So Kris, I might just jump in here. KHA has been a long-standing supporter of expanding Medicaid for years. I think Sarah made a really good point. Bottom line, it's bringing some additional revenue into the system, which is only going to have benefits. I think each Kansas community is different, and the folks and the makeup of that community does look different. And for certain pockets of our state, expanding Medicaid really truly will expand access to healthcare services, because there are places where folks just simply don't seek care today due to the economic realities of their situation. And if we can make that care more affordable, we're certainly going to provide additional access for them, improve the overall health of those individuals. In addition, one of the challenges that a lot of our hospitals face, including small rural hospitals, is uncompensated care provided to folks who come in the door. We don't turn folks away. We take care of every patient that arrives at our facility, but we don't always get paid for those patients. So certainly having some revenue come in the door, whether it's not always the same amount of revenue, because each payer, even within Medicaid, you get paid different rates depending upon the company that's providing the coverage. But some revenue is certainly better than no revenue. So part of the challenges facing our small hospitals is due to that lack of coverage. And certainly expanding Medicaid will help with that. It's not going to fix all the problems. And I think, as Sarah found in Fort Scott, there are lots of factors that go into the struggles that a hospital faces. But this is an action that we could take today as a state that is only going to have some help and some positive impacts on the overall situation.
So we have, Medicaid expansion, continuing discussion in Kansas will probably come up again during the next legislative session. Unknown what might happen with that. And we also have this, rural emergency hospital model that's also coming out. That's a separate thing. So what can you tell me, Jennifer, Kris, PJ, where are we at with this model, and how close is it to being something that benefits communities, and what are the steps in the process? What's the current status of this?
Sure,
idea?
Maybe I could kick this part off. So this concept of trying to find some solutions for our small rural communities, we at the association started working on a number of years ago. In 2012, we were starting to see some of the challenges coming and facing our rural communities. So we did what Kansans do. We decided to roll up our sleeves and figure out how to tackle this. So we pulled together a group of our members. Rita Baker from Fort Scott was one of those active participants, where we said, we know some rough times might be coming, and we want to find a solution. We want to be ahead of the curve. We want to have an option that we can put out there for communities who aren't able to sustain their hospital any longer. So we really challenge this group to think outside the box, to throw out the rules. And if we could start over, what would a small rural community really need? What is the access that is absolutely essential? And they created a concept that they called the primary health center. And for a number of years, we tried to convince the feds that we had an idea that really needed to be tested and that we wanted to try this out in Kansas. And we had some communities who were really willing to step up and give it a shot. After going through many steps with CMS and through their innovation center and talking about possible challenges and ways to implement, we weren't quite there. They kept asking questions, but they never gave. At the same time, we were working with our congressional delegation and others to advance things that were happening in our state and in other rural states. And we were handed a number when Congress passed the Consolidated Appropriations Act. While most of it talked about COVID relief, they snuck this little piece in and created this new thing that they call a rural emergency hospital. It's essentially the same thing that we started with the primary health center. It's a facility that's open 24/7. It has an emergency room. It can focus on primary care. It doesn't restrict outpatient services. The one unique difference, as you've heard before, is that it eliminates those inpatient overnight beds. So if you come into the emergency room as a patient, you find at hour 23 that you really still need to stay in the hospital, that's when you would have to be transferred. It opens the door for lots of creativity, lots of additional services to be provided. So in the bill that passed, it first of all says that you can't start operating a rural emergency hospital until January of 2023. Lots of reasons for that. One, communities and states have to get themselves ready, but CMS also has to get ready. This was not really their project. This wasn't something they advanced and asked Congress to give them permission to do. This is something Congress told them to do. So they're in the middle right now of a process of figuring out how to implement a mandate, just like many other federal mandates that come down and are handed to agencies. So they're in a rulemaking process right now, looking at how they want to shape this program, how it would work for those communities and hospitals that are interested in receiving it. They've issued an RFI, a request for information, asking folks for their opinion about this. And that RFI is currently open. It closes on September 17th. After they receive that input, then they will go through a process of rulemaking, and they'll first develop proposed rules. Then they'll put those back out for public comment. And then after they've received the comment, we'll go to the final rulemaking process. So we're still a ways down the road from truly understanding how all of this is going to come together. But in the federal bill, they also said that in order for your state to take advantage of this opportunity, that you needed to be able to license and operate a rural emergency hospital. So we took quick action to work here at the state level with our legislative branches to introduce a bill, which we're fortunate made it all the way through the process, has now been signed by the governor, that creates the rural emergency hospital designation in Kansas. So we have paved the way here in Kansas to be ready to take advantage of this opportunity as soon as we have communities interested.
So that feels like the legal and the financial framework that would need to be in place for this change to occur. But that's not the only thing that has to happen, right? Like communities have to choose this.
Yes, it's an important piece, but you're right. There's an even bigger, more important piece, which is this idea of communities really starting to talk about their future. And that's why we started this project that we call Community Conversations a number of years ago. We were fortunate that we found some great partners here in the state of Kansas, the United Methodist Health Ministry Fund and the Kansas Health Foundation, who shared our concerns about what was happening in rural communities and really wanted to find a way to start a dialogue to help folks understand how healthcare is being used. What does their community utilize, and what are some options for the future? What does the projection for the future look like? We find that oftentimes the reality isn't really understood by the folks that live in the community. And I think things that happened in Independence and Fort Scott show us really a great example of how the general public doesn't always understand the realities facing the hospital. So we started out just really wanting to have that conversation, to talk about what's happening, and then maybe seed the ideas of some change. We now have a real true option that we can put out there for them to chew on and talk about even more. We were really fortunate that Kris's hospital, Decatur Health, stepped forward right after we announced this opportunity and welcomed the opportunity to have a conversation. So we got to have that conversation with them in person in March of 2020, right before everything shut down. We got to go to Oberlin and engage folks in this conversation. So it was a good first step, I think, for them and starting to think about the future and just really educating folks about what's going on.
So, Kris, I'd like to bring you in now. What was that conversation like? What did it feel like to have that conversation in your community, and how did it go?
I thought it went a lot better than I could ever hope for. I was very nervous about putting on the community conversation, but we got to a spot in 2019 that, much like you talk about Fort Scott, our story is very similar. We stopped doing OB back in 2008, and I think I get at least 10 questions a year about why you need to start OB up again, and how expensive that is. We always say that we no longer plan to do here, and so, because at any moments in time, our emergency department may have a labor delivery there, which in 2016 or July, we delivered a baby in our ER. And so we transferred him over to Norton for follow-up care. And so we just always say that we just stopped planning maternity care and deliveries there. But I knew that we had to get out into the community because we had to let them know what our is like. We've seen our inpatient volume continue to decline. I think we had maybe 4 admissions probably in the month of May, which we normally average 10. On those acute patients, the med-surg patients, they are not here that many days. And so for a small hospital, getting the bills out and getting the cash in is the way that you can operate. And we started seeing cash just going to the negative, and made it very, very, very tough to operate. And so when the primary health center model that Kansas Hospital Association was talking about with the community conversation, I went to our board and said, we have to get out into our community. We have to educate them about what this model could be, because if there's any financial way that we can make this work and it'll allow us to keep something as far as healthcare in our community, this is our ticket to do it. And so with the Kansas Health Foundation and the United Ministry Fund and Jennifer and the Kansas Hospital Association, they did a great job of working with us and prepping us. The models that, they had open, small groups. They had it planned out that it was very interactive for all of those folks that could come. And so we offer some food, and then we put out some different displays about, hey, did you even realize that we are a licensed, 24-bed hospital, but we only have 3 inpatients on average every night. And 2 of those 3 patients, PJ, are our swing beds. We have, they take probably only a third of the admissions are swing beds, but they're here for many, many days. They're coming back from surgery and they're doing the rehab, they're getting stronger, and then they can go back out to living at home. And so, yeah, the swing bed is an inpatient, and what we're talking about with this rural emergency model is, at least for right now, what we're planning for, if we were to go this route, is just acutes is all that we would be losing, which that is only, actually it's less than that. So we're not talking a lot of patients. I'd say we average 10 acute admissions a month, but we also transfer out quite a few folks from our ER and inpatient to a higher level of care because we don't have an ICU here. And so I was trying to educate them that overwhelming majority of our community's care can be delivered on the outpatient side. Historically, we were about 50-50 on the revenue from inpatient to outpatient. And, in 2019 or 2018, we were more like 85 to almost 95% outpatient compared to inpatient.
And does that remain true, like even with COVID, that like inpatient beds, is that a curveball that you've had to deal with, or is that factor into this?
COVID has kind of impacted that a little bit, but rural communities will always have to have an ER. Guaranteed. There's way too many farm accidents. There's way too many things happening out here that to not have an ER would be devastating. And my heart goes out, that story that you talked about with pulling up to a closed hospital with no ER. So yeah, we have to have the ERs where it's at, and then primary care and all your ancillary services. I mean, if we can keep the swing beds too. So that's a model that could work for us if we have to go that route, if the finances would follow.
When you have the community, go ahead, Sarah.
Yeah, I just wanted to ask Kris how far he is from another place if you didn't have an ER. And then also I wanted to ask Jennifer about the swing beds, if those are part of the rural emergency hospital thing right now. Okay.
They're close to 25 to 30 miles in all four directions.
When the rural emergency hospital legislation passed, there's a set of services that they require every rural emergency hospital to provide, emergency services being there at the top. And then there are a set of services that they left the door open for a community to individually decide. And swing bed services is one of those options. So it's not a requirement, but it is certainly an option for a community. What has changed is the way that they are financed. And we could spend a whole other hour or two explaining the complexities of healthcare finance and how hospitals get paid. But the short version is they've changed the way that you get paid for those services. So each community is going to have to do an analysis to decide if they have enough volume to make that kind of a service work well.
Right. So Kris, when this conversation came up in your community, like were there things that were harder or easier for people to grapple with or accept, being part of the future?
Well, 2015, our hospital had a nursing home that was attached to it. And so much like losing maternity, when they closed the nursing home portion of the hospital, which we were fortunate to have another organization that had a nursing home here in town. And so they didn't have to go that far, but they felt like it was something that they lost in their community, much like the emotions that come with closing of a hospital that you talked about in Fort Scott is the same way with closing the nursing home here. But financially, it was the absolutely one. It really helped the reimbursement financially to save the hospital and keep it going. So as we started educating the folks that came to the community conversation about, here's what we're running through, and here's what is an opportunity that we can stay on the outpatient side and we can still meet all of your needs. And you're only talking about a slim chance of being an acute patient, where hopefully you wouldn't have to go that far, and we would work on a transfer agreement for that, which was still pretty difficult as you're going out to the community to talk to them about a service line, inpatient service line, going away. And it still leaves a bad taste in my mouth to think about, here's one thing that we can still do in rural America is we can still care for, an acute patient. And we've seen that in COVID because, we got to spots where we couldn't transfer patients out and we were taking care of some really, really sick inpatients, and we can still do that. And I always say we're not going to start up an open heart surgery program anytime soon, but inpatient med surg care is something that we can still do in rural America. And I really hate to see that go. But if it come down to, hey, we don't have the money to keep the doors open, or then that's the choice. I'd go for the rural emergency hospital if funding was there.
Well, thank you for that, Kris. Sam, we have about 10 minutes left. I'm curious, anything else coming up in the comments or chat that might be worth tossing back to the panelists?
Yeah, there's been more comments, questions, and discussions since the most recent inquiries. Janet Podol is wondering about the attrition of competent healthcare providers who decide not to work with this model, ER docs that don't want to work without the backup of a hospital, nurses that want to work in the hospital, lots of different services. Another concern is data relating to maternal infant complications due to distance from the services, and numbers regarding children receiving long-term health care and education services due to birth complications relating to distance from home to appropriate level of care. Let's see, there was a couple other things I wanted to mention. Someone was very encouraged to hear about the details provided by the Kansas Hospital Association. So there's some hope to properly prepare for this and consider a different way of approaching it. So there was some encouragement there from Dave Herdman. One criticism was that the funding, wanting to repeal CanCare, and that the funding that goes to MCOs doesn't really go to services, doesn't go to Kansas, doesn't go to facilities, and it goes to the MCO. So it's saying it's a politicized untruth that Medicaid expansion will actually fund rural hospitals. So I don't know if we want to comment on that, but that was a strong comment that came in. So there's different options to pursue.
Yeah. Does one of those questions feel alive for one of our panelists?
Maybe I'll talk a little bit about the workforce issues, because as we've had these regional virtual conversations and started to spread the word, that is an issue that always gets raised. And we know, as you know, others have talked about, healthcare is very important to our local communities. Important because they want access to care and to make sure it's there when they need it, but also important because your hospital is oftentimes one of the largest employers in the community, and it's an economic development piece of the overall structure of the community. So there's always been questions about what will happen to the folks that work at the hospital. And I don't have a crystal ball, and I can't predict exactly how this model is going to look once it's in operation, but we're still going to need staff in these facilities. And if we're providing the services that are often most used in a community like Kris explained is happening today in Oberlin, the folks that deliver those services are still going to be needed, whether they're called a rural emergency hospital or a critical access hospital, which is what they're called today. We may shift responsibilities, and some folks may be doing something different than they did before. But for our hospitals who have really tried to right size, to run the most lean and mean operation that they can, and I think Kris is a great example of an organization that has really done that. They've really tried their hardest to, economize. They aren't going to lose much from a staffing perspective because they're pretty lean and mean as it is now. And quite frankly, they do a fabulous job with the small number of folks that they have working in that facility today. So there could be an impact, but we don't believe that it's going to be a huge impact.
Right, you're exactly right. We have two nurses on and one aide, and that's pretty much 24/7. So the acute patient, you're talking 100 patients a year. Those nurses are also doing all the swing beds. They're taking care of all of the ERs that come in, which we average about 2 a day. And then they're doing all of the outpatient therapy. So any IVs or injections, they're handling those. We have a general surgeon that comes in on Wednesdays. We do scopes, lesion removals, pain management. And so they're also helping out with some of those outpatient and those procedures. So if we got rid of the acutes, we'd still have a whole list of things that they would have to be responsible for, with the ER being the top one. So if we were able to do it my way, we would not see a big difference at all in our staffing.
You know, one of the challenges that our small rural communities face is attracting a workforce. And some folks have shared that they think this new model is actually for some of those facilities to attract new workforce. A component we haven't even talked about today is telemedicine and the true power that has to continue to provide access, but also provide some great services and support to the staff working in the facility. And we envision, and CMS also has shared already, and even in the federal legislation, they mention the need for a strong telemedicine component as part of this new model. We have a number of hospitals across the state that are utilizing backup in their emergency rooms today through telemedicine. And many physicians have commented they would not go to a hospital that didn't have access to those kinds of services ever again, because it is such a help. So, and another component we haven't talked about is we envision a relationship between a rural emergency hospital and a larger hospital that can provide some support services. So we don't think these hospitals are going to be out there completely on their own. They are going to have a support system around them to help make sure that things are working well and that they can get the care that patients need.
Thank you for answering those questions, Jennifer and Kris, and thank you for everyone who's watched. I really like to end these discussions by trying to maybe go back to like big picture. And so in a moment, I'm going to ask each of our panelists to sort of weigh in on like, based on what you know, like what do you see as like a really big question that rural communities are going to have to answer in terms of sustaining healthcare over the next 10, 20 years? And I'll actually start because there was one that I wanted to try to answer with this panel that I wasn't able to. And I was really curious with the census numbers, like a lot of these areas that are losing population are also seeing a growth in their Hispanic population. And I wondered about like what the impact on Hispanic and Latino health would be, that community is surely growing pretty much across the state at the same time that some of these services are changing. And I'm just curious about how those dynamics play into each other. And I haven't found an answer to that yet. So Sarah, Jane, Jennifer, PJ, Kris, what's on your mind in terms of questions that might need to be answered going forward?
I mean, I'll go first, and that is this idea that the communities are changing, right? I mean, I grew up in Parsons, Kansas, and it's lost thousands of residents since I left after graduating from high school, and the communities are changing. I think that's perhaps the first question communities should ask themselves is how have we changed? And then the next one would be how has healthcare changed over the years? Because people aren't in hospital beds as long as they used to be for the same services that you think of. Something Kris mentioned, and this idea that people bypass the local hospital to go to specialty services in, say, a Kansas City or Wichita is very real. And so these hospitals have empty beds, and that should make communities ask, well, what do we really need? And once you accept that your community has changed and accept that people aren't maybe using the hospital like they would have in the 1980s, then you can ask, what services do we really need with an open mind? And that would be kind of the big thought that I had after covering Fort Scott for a couple of years was this, oh my gosh, it's all different than I thought. I walked in with these assumptions or maybe these preconceived notions of what healthcare was, and none of it was right. I was far off the mark because I was 20 years behind where I need to be. And so that's kind of the thought process I have as I'm listening to everybody talk today.
That's great.
And thank you.
Yeah, I'll just throw in, and not that I have any answers, but it's more along how is America or United fee for service to the value? You know, the cities are always talking about that, and in the rurals we're in the same boat. We just don't have the volume. So how can we get reimbursed for the value? But we're going about it all the same way that the city hospitals do. We're trying to engage those folks even before they have a clinic visit. We're trying to make sure they're getting blood pressure checked, that we're managing the diabetics. It's still population health, and it's still the prevention. You know, that's been our MO for years to try and get them. So it's more of a value. It's still the value-based question for me.
I would agree with everything that Sarah and Kris have said. I think it's look at what do they need, what are they willing to support, because that local support piece is absolutely critical. A number of our small hospitals wouldn't be open today if it wasn't for the tax support that their local community provides to keep the doors open, and that's going to continue to be an issue. So engaging in these conversations about what they're willing to support and sustain in the future now, before there's a crisis, I think is absolutely important for every community to start to talk about.
Thank you. That is correct. Our county gives us some tax money. We would not be here today without the support.
So thank you, Sarah, Jennifer, Kris. PJ, what's your next story on this going to be? What's the next question you're going to try to answer?
Well, I'd like to keep up with communities that are actually having the conversation and see how it differs from county to county as you go across Kansas, because I think you're going to find that these rural communities have more in common than a lot of people think they do, but they also have a lot that's very, very different. And that just is a function of ethnicity in some places. You know, Garden City is never going to look like Phillipsburg. the history and the traditions of a community are really very different going east to west and north to south across Kansas. The common thing that those communities have is that question of what does our community need? And my biggest concern to follow as I follow this story is, are we making sure that we're keeping the legislation on track to give these communities the flexibility they need to address their community's need without trying to make a model that fits everybody in the United States?
Well, thank you for that comment. Looking forward to seeing what you might bring to the journal in the future. Thank you to our panelists for your insights today. I thought it was a very interesting and thoughtful conversation, and grateful to have you here. And thank you to our audience for joining us and for being actively engaged and commenting. This concludes this episode of Journal Live about sustaining rural healthcare. Join us next month when our topic will be about the history of sundown towns in Kansas. Until next time, see you then.